Good afternoon, everyone, and welcome back to the fourth and final session of our 2020 Texas Benefits Forum series, hosted by the Texas Business Group on Health. I hope you enjoyed the first three sessions last Wednesday and Thursday and yesterday, and came away with useful insights that you can apply in your own work. Today's session is on emerging strategies to incorporate social determinants of health in benefits design. But before we launch into the session, I've got a couple of reminders. One, all four sessions are being recorded, and we will send everyone who registered for the series a link to each session to review and or download. They will be up and available for about 2 weeks after this is over. We also will send everyone who registered a very brief survey, like a 2-minute one, which I hope you all will respond to. It's really important. This is our first virtual big event that we've done. And we've had other smaller virtual group meetings, but this was a real interesting endeavor to set this up, and it will be really helpful to know if it worked well for you, and also how we can improve for future virtual events, which we will have more of this year. I also want to go to the next slide and recognize and thank all of our forum sponsors who have made it possible for us to offer this high-value educational program for Texas employers and their benefits services partners. So we invited each of our 9 sponsors to showcase their company and some of the useful resources available to employers in one of the sessions. We divided it up. And today, our sponsor spotlight is on Merck and Boehringer Ingelheim. They are both longtime supporters of TBGH and our programs. What we'll show first, I'll recognize Keith Ingstadt. He is our account manager for Merck, and he's chosen a video to share with you today, which I think you'll find quite informative. Thank you, Keith.
We try to remember that medicine is for the patient. We try never to forget that medicine is for the people. It is not only for the profits. The profits follow, and if we have remembered that, they have never failed to appear.
Thank you, Keith, so much. And thank you, Sam Jones, for your support as well. I know you and Keith work together on this, and we appreciate all you do for Texas Business Group on Health. Let's move on to Boehringer Ingelheim. I want to thank Marcus Laughlin. He is our account manager who has been very supportive of our educational programs and engaged in our our coalition as well. So Marcus has also sent us a video that I'd like to share with you.
Boehringer Ingelheim has stood for innovation and responsibility for over 130 years. But how did it actually all begin? On July 31st, 1885, Albert Boehringer purchases a small tartar factory in Ingelheim in southwest Germany. A few years later, he makes a groundbreaking discovery. Thanks to his innovative spirit, he finds a way of producing lactic acid in industrially relevant volumes using biotechnology, thereby making a lasting change to the market. Soon after, Albert Boehringer develops another pioneering business area. His company extracts alkaloids in order to supply them to pharmacies and the budding pharmaceutical industry. Based on these plant-derived active substances, he puts the first of his own drugs on the market, laying the foundation of today's core business. The next 2 decades are characterized by growth. New medications are launched for different indication areas, and new sites are built up. These include Biberach in Germany's Upper Swabia, today still the company's largest research site worldwide. From 1948, Boehringer Ingelheim enters new territory and establishes its first subsidiary outside Germany. Many more follow. The company employs about 50,000 people worldwide by 2017. In the 1970s, Boehringer Ingelheim expands to the US market and establishes a new field of activity: animal health. Biotechnology is also expanded further, and the company's first biotechnologically produced drug for treating acute myocardial infarction is approved. Many more milestones follow. The transfer of HIV from mothers to their unborn children can now be prevented. A medication for the debilitating lung disease, COPD, is launched, and it is today Boehringer Ingelheim's best-selling medication worldwide. For the first time in 50 years, anticoagulants with a completely new mode of action can be given. Boehringer Ingelheim successfully enters diabetes research and achieves an outstanding therapeutic success. In 2016, veterinary medicine is strengthened significantly. Through a swap of business areas with Sanofi, Boehringer Ingelheim becomes one of the world market leaders in animal health. And success will continue. The family-owned company will in future collaborate even more closely with startups and universities to support their research with development know-how and clinical studies. The Boehringer Ingelheim story is a classic example of true innovations. And the next innovation is surely on its way.
Thank you very much, Marcus, for your support and for sharing this interesting video. Okay, let's launch into session 4, which is emerging strategies that incorporate social determinants of health, sometimes called SDOH for an acronym. We're just like the military, and healthcare has lots of acronyms, in benefits designs. We're going to talk about the racial disparities and social determinants of health, such as socioeconomic status, education, neighborhoods, physical environment, employment, and other social support networks, as well as access to healthcare that feature as prominent factors in people's health and health outcomes. And we're going to talk about and learn about some benefit strategies that are designed to mitigate the negative impacts of social determinants of health on employee health and access to quality health care and better health outcomes. So with that, I'm very pleased to introduce our speakers. Dr. Scott Conard. He is our Dallas-Fort Worth Business Group Medical Director. He is also a practicing family physician who has a practice called Converging Health. He is passionate about transforming healthcare to provide more convenience, increase access, and significantly improve quality and lower healthcare costs. He believes that the surest path to reduce costs lies in a better model of care that embraces preventive care, early detection, excellence in management of known conditions, and improved behaviors. Dr. Conard is also going to be our moderator for this program with our other speakers. And so pleased to introduce my colleague and co-executive officer of a coalition, the Pittsburgh Business Group on Health, Jessica Brooks. Jessica is leading the effort to redefine and advance the discussion around healthcare value, access, and quality on behalf of employers. She is spearheading many new initiatives and measures that have resulted in improving the PBGH, Pittsburgh Business Group on Health's organization's visibility and growth in the healthcare marketplace. She is a pace setter in the coalition movement, and all of the other coalitions, including TBGH, DFWBGH, and the others in Texas, follow Jessica's lead in many regards. Thank you, Jessica, for participating today.
Thank you.
And we have Tammy Fennessy as well, who has joined us. She is the Director of Benefits for American Eagle Outfitters. She's responsible for managing benefit programs internationally and for all 50 states in the U.S. for all AEO brands. She also serves as president of the Employer Board of Directors of the Pittsburgh Business Group on Health. And I'm sure, Tammy, you have a lot to do with some of the innovations that Jessica is able to bring forward for the whole Pittsburgh area and beyond. Tammy's key initiatives include leveraging technology to build efficiencies, population management, and removing barriers to benefit program entry and navigation. And of course, all of her benefits plans and initiatives are very well aligned with American Eagle Outfitters' strategic objectives and culture. Thank you for joining us, Tammy. We appreciate it. So with that, Dr. Conard, it's all yours.
Thank you so much, Marianne. You know, it's so exciting to be here with you today. You're going to hear something that the very few people in the United States have ever had exposure to. When Jessica Brooks and Tammy and I did this presentation nationally, we really had so much positive response. And it's a different, unique way of thinking about the things that we're going to talk about. So for me, this journey began in March when I got a phone call from a company where they'd had an outbreak of COVID. Very quickly, that outbreak spread, and over half of their employees ended up getting COVID, and a number of them died. And so it was, you know, that was Danita Dubé, who many of you know, and I all of a sudden found ourselves spending time at a factory, literally walking through and trying to understand what had happened that had led to this terrible condition. And what that led to was interviews to talk to people, to ask, where did you get exposed? How did you have that occur? Was it at work? Was it at home? What happens? And what we really discovered was that this COVID epidemic was revealing a huge deficiency in our healthcare system, and that the people who were actually would have to participate in taking care of themselves weren't. And when we interviewed them, we asked them why. Why was this? Why were they not engaging? Why were they not doing the things that would prevent COVID? And what we found out is many of them had data privacy concerns. They didn't want to really have their information. They're afraid who would see their information and things. There were language barriers. There were educational level barriers. In fact, some of them couldn't read or write. There was health literacy problems, including understanding what COVID was and how it was spread. They didn't understand how to use the healthcare system. They didn't understand how to use their benefits. As many of them had great benefits, but never utilized them. And one such person, the one that really I'll never forget in my entire life, is a gentleman who was found dead in his home. He never called 911. He never got help, even though he had everything at his fingertips that he could have activated to save his own life. And then we found that there were cultural beliefs about the healthcare system and how to engage in it. There were multi-family, multi-generational cohabitation that led to rapid spread. There were social customs that led to people spending more time with each other. People were driving to work, 4 people in a car, and obviously that's going to have them be within 6 feet of each other. And then there were trust issues, trust of the system, trust of the political system, trust of their employer that kept them from engaging. So what COVID has done is reveal the Achilles heel of our healthcare system, which the term that people use is social determinants. And we just wrote up all of the things I shared with you, and it's going to be published in a very significant national magazine, a journal, medical journal, with Johns Hopkins and I, and gentleman named Ned Kusti, who has worked with the business coalitions across the country extensively. And we define social determinants of health as conditions and environments in which people are born, live, learn, work, play, worship, and age that account for 60% of health outcomes. They affect a wide range of health, functioning, and quality of life outcomes and risks, including social, economic, and physical conditions in various environments and settings such as home, school, church, workplace, and neighborhood. So that is the boring definition of social determinants of health. But today with us, we have really a national superstar with amazing charisma who is really redefining how we think of social determinants. Go into the next slide, if you would, please. And in speaking about that, she is reframing what are social determinants, how do they work, and how do we as corporate entities or people who support corporations define and address this huge issue that's affecting people, literally probably causing more lives, leading to more suffering than anything that has to do with the quality of the hospital or the doctors in your community. And so with that, I'd like to turn it over to Jessica Brooks to share her vision of what she's seen and how we can do something about it.
Thank you, Scott. I really appreciate that introduction. You always make me have to live up to the expectations you set. You brought up quite a bit in your opening remarks, and I'm glad you ended with the trust factor. Oftentimes when we are talking about the reasons why people aren't compliant, it can come across as if it's as finger pointing. And I'm glad that you brought it back to, we have an accountability in the healthcare delivery system to build trust and to earn the trust of those patients. And yes, it's in their best interest to follow your guidance to keep themselves safe from the health perspective, but it's also your responsibility not to require them to live the way you do and have your cultural norms and understand their cultural norms in the way that they can be healthy within their cultural norms. Assimilation is not the answer. It's understanding and compassion and opening ourselves up to realize that maybe if we just understand them a little bit better, we'll be even smarter, we'll be healthier, we'll know how to be better connecting with people and know how to really get to true quality of health. So I'm proud of the work you're doing with Dr. Kusti, who's a medical director for us at PBGH. I can't wait to read it. And I just can encourage everyone to stay on their journey because we have a lot to learn. And the social determinants of health movement sounds really, really good. And on the surface, I think it's missing something. It actually had us going in with the right intentions, but maybe in the wrong direction when it comes to addressing the 80-20 rule of what really impacts your health. And you have some of those things listed on here. However, social determinants of health is a symptom itself. And as a physician and those who are clinical in the audience, you want to get to the root cause. We have cough medicine to address the symptom, but that's not why I'm coughing. And so the food deserts are a symptom. Not having access to food, the appropriate housing, safe environments and neighborhoods are a symptom of something underneath all of that. And the root cause of that is racism. And racism is purely the denial of quality, access to quality. And if we focus on how do we provide access to quality, we'll address racism. It's really, it comes down to that. But when you think of, the history of this country, and if you just go back to the conventional wisdom of slavery starting in 1619, that's over 210 million minutes that we have compounded of actions that have resulted into these symptoms. And so I know, so that's really the lens that I've been taking. And then when you take it down to the root of denying the denial of access to quality, then we can work from there. We have to address the symptoms because they're there, but we have to realize that we need to start at the root. And everything that we do in our practices, our processes, our procedures, our statements that we make, and the actions that we take should be aligned to that overall goal. Is this getting in the way of access to quality, or is this enabling access to quality? You mentioned COVID-19, and there was a lot that was outlined in COVID-19. And I think what we saw was the result of those 210 million minutes coming to the surface and being visible for everyone. But rest assured, our health systems have known about these disparities. Our insurance industry, our pharmaceutical industries, employers even have known about disparities. Disparities isn't a new thing. However, we're at a time where I think we're all ready to do something about it. And I'm excited about this opportunity that's before us. And I'm excited that it's happening in my lifetime. If you think about, I will get more into this in our discussion, I'm sure. But last couple comments is, I really want us to understand the responsibility of health equity. And I think the Robert Wood Johnson Foundation has a really good definition that I'll read. And it states, health equity means everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And I think I love that definition. So it's not just listing the social determinants of health, but it's talking about the responsibility we have and understanding that discrimination has a part to play in that, and that there is opportunity to provide higher quality and power for people to realize food security, housing, and safe environments, et cetera. So I'll stop there and see if you have any questions.
Yeah, cool. So go ahead and take the slide down if you would, just for a minute, just so that we were all here on the same page. Although, yeah. So it's what I hear you saying, Jessica, and what I found most intriguing about our initial discussion was that maybe it's not an accident that Black Lives Matter as a movement appeared during the COVID epidemic, because as we started to see the inability of employees, and let's just stay with employees and their family members during the COVID epidemic, being able to get access to care, and the holes of the access to quality arising, that may have in some way, shape, or form actually been a burner underneath the Black Lives Matter movement that started to have it arise. How do you think about that?
Well, the Black Lives Matter movement has actually been along here longer than COVID. It's been around for many years, and actually resulted out of several police shootings that had happened several years back, of the many police shootings that have happened over the recent years. So it actually has had its legs. I think the COVID-19 reality aligned with the social reform and police reform reality. And it basically had this underlying factor of our lives don't matter based on the outcomes. And that resonated because we had more people talking about, well, why are Black and brown people dying more? And they don't, more than they even represent the population, contracting the virus more. And many people say, oh, well, that's because they're in vulnerable jobs. Like they drive buses, they are the cashiers in the grocery store, the places that are staying open. Well, why is that? They're the majority of people. They take care of people. They're nursing aides. Well, why is that? Why is it that they're disproportionately represented in the service roles? What is the history of that? And people just started asking the question: Is that a good enough reason for people to be dying because they're exposed or they're in an environment disproportionately than others? And so I don't know if that answered your question, but I do think the Black Lives Matter movement was validated by the COVID-19 reality. And even Dr. Fauci, who many of us have been following this time, said African Americans have suffered disproportionately from coronavirus. They've suffered in that their rate of infection is higher rates because of their economic status. And then he mentioned the fact that they're working outside, unable to be as physical. And then when they get infected, given the social determinants of health, which make them have a higher incidence of the disease like hypertension, obesity, diabetes, et cetera. So it's all connecting, I think, and that's, we're at the epicenter of that. And we have a movement, a social movement, I think that our healthcare industry needs to catch on to and have a rural healthcare reform movement in the way of quality of life for everyone.
Well, it's interesting because as a result of this, and my experience I had with that first company I talked about, I'm the chief medical officer for Holmes Murphy, which is a large brokerage firm that's in North Texas a lot. And we actually have gone through and created an affordability index where we look at the companies that we serve's ability for people inside the company to use their benefits. And, you know, we're finding 15 to 20% of people we're just starting this right now, but 15 to 20% of people aren't even able to use the benefits that they have. And that's what we found with that first company, which really validates what we were seeing, is that with high deductible health plans, people were checking out. They weren't getting their medicines, they weren't going to the doctors because they just couldn't afford it. And it's wonderful today to have Tammy Fennessy on the call, where she's going to, or on the presentation, where she's going to share what one company is doing to really address, and that's what the whole rest of this conversation is going to be about. Not theoretical, but practical. How do you put this on the ground? How do you make sure that the folks inside your company, the employees and their family members, actually have access to quality and take the responsibility? I don't mean that's a negative, but like in a positive, inspirational responsibility to make sure that you actually have access for everyone to high quality, and you stop them in the sense that, and we'll come to this again in a minute, I'm just planting a seed, that you actually make it impossible, or you prevent them from being exposed to low quality care. So that said, Tammy, would you share with us what you're doing and what your company's doing to help address these challenging issues?
Sure, I'd be happy to. And just to start, I just want to thank you for having us. I love working with Jessica with the Pittsburgh Business Group on Health. I just want to put a little plug out there that she's just an amazing leader that has really brought visibility to the health equity and mental health disparities that we see in our communities. So thank you for letting us share our story again. This first slide here, and I'm not doing a commercial. I want to make sure that you all understand kind of my landscape and the challenges that we've been up against, in regards to, especially during like COVID-19 and how we address that from the forefront and how that plugged into a lot of the challenges that we were trying to face, in regards to social determinants of health. So we've got about 40,000 associates. Only about 8,000 of them are actually full-time. The rest is a part-time workforce. And we're in, the US, Canada, Mexico, Hong Kong, and China. Very geographically disparate, obviously, with 1,000 stores. And then we've got 3 distribution centers and 4 corporate offices. And I thought it'd be interesting for you to see kind of like our generational breakdown, because, when you look at like our population as a whole, we have a huge Gen Z population, followed by millennials and then Gen X and baby boomers. And we've only got, 2% baby boomers, 6% Gen X. So, I mean, we're predominantly in that millennial Gen Z framework. You can go to the next slide, please. So just going right to the chart that I have here, when you break that down though on who's like enrolled in our medical, the story changes. And like the reason I really wanted to talk about this a little bit is just data is a big part of what I pay attention to in our programs, and understanding like how things are, not just from like the overarching, high level view, but understanding like who are the people that are on our plans and what are their challenges and what are they going through is super important to us. So while we may have a ton of Gen Zs, in our organization, we are only looking at 3% of them in our medical plans. So we're catering a lot of, I think, our programs and designs towards the millennials and the Gen Xers. And then obviously, you know, have a very crafted approach towards those that are baby boomers because of the chronic condition management. I do want to state that when we went into COVID-19, out of those 40,000 associates, 36,000 of them were furloughed. And right out of the gate, we had, you know, our senior leadership, you have to understand, I mean, we are not, you know, we have very tight margins. We're in retail. So when you're talking about that space, I mean, you are talking about a lot of people who are not making a high dollar, you know, wage and everything else. And I think our leadership has a lot of understanding and really wanted to be incredibly supportive as we were going through this incredibly challenging time. From the beginning, they agreed after I crunched the numbers, I shared with them what the implications would be. We covered everyone's benefits, voluntary and involuntary. So even if they were in, like, you know, just an employer paid or employee paid benefit, we continued making everything whole. So they never lost that, which in my opinion was just incredible to work with an organization that would support an initiative like that. And we had people that were on furlough for, you know, over 3 months. So it was not a short-term type of commitment. Did also want to point out that those that were, you know, are enrolled in medical insurance, 66% of them are female. So we do a lot of benefits around supporting new parents and, you know, families and things like that, because for a lot of these folks, they're having their first children or child. And the average age of our employees that are enrolled, if you take all belly buttons in, it's about 37, but when you only look at our average employees is 37, when you take all the belly buttons into consideration, and it goes down to 30. So it's a very young group that we're talking about. So all of that being said, it's really, we really don't have much of what we need from a data perspective. And that's kind of why I wanted to, like, just share this part of the story. I mean, even though, I mean, I can go into data and I can look at, you know, advanced analytics, claims data, drill into, you know, where I'm seeing disparities in care, much more so than I can identify the social determinants of health. So we want to go to the next slide, jump into some other, some kind of action steps, at least, you know, from the beginning. So knowing what we know and what we knew going into, you know, and trying to cope with, you know, COVID-19, and then, you know, to put right on top of that, you know, all of the issues of, you know, racial inequality and the, you know, just systemic racism. You know, there's a lot going on, and I don't think neither of these are going away. You know, we have to, to my, you know, the point of my second bullet, you can't be silent. And I think we have to all be willing to put ourselves in very uncomfortable spaces, and have uncomfortable conversations, because I don't think you're listening or learning how to take proper steps and learning what people's needs are unless you're willing to go there. I also think we need to be willing to make mistakes. Like, we can't wait for people to pave the road for us. We have to be leaders and make change happen. So just, I'll get off my soapbox, but it's definitely, I think that we've done some things that have made a difference in people's lives from the onset of COVID-19. It's definitely put a fire under me to make sure that, like, this continues. This is the right path. We have to be, you know, doing things like removing barriers to care. Mental health is something that is a huge issue, not only, you know, in Black and Brown communities, and in, you know, LGBTQ plus communities, and just, you know, in our backyards. And, you know, one of the things Jessica and I have talked about a lot is you can't take your workplace family and separate that from your community. They are one and the same. So we all have to, like, work together, and that's what will make businesses so incredibly strong, is if they actually don't put their heads in the sand and do something about it and take action. So some of the things we did, we went ahead and immediately, as soon as the, you know, CARES Act came out, and I believe it was the CARES Act, not the Secure Act, that said that we could go ahead and allow people on high deductible health plans to access telemedicine without hitting their deductible. We immediately made the change. And before, we had, like, even $15 co-pays for our, like, PPO plan, our HRA plan. We got rid of those as well. So it was just, you know, 100% coverage on all telemedicine, both medical and behavioral health. We put in on-site on-site clinics and health coaches, which I think was huge. To Scott's point earlier, I mean, we were looking at one of our distribution centers. We had definitely had language barriers. We have about 60% Spanish speaking at one of our distribution centers. And when we compared that to one of our others, their COVID-19 cases were off the charts compared. So we had put in a health coach that was bilingual. We put a nurse on at each of our distribution centers and opened it up to everyone. So they didn't even have to be on our medical insurance. But they had somebody there that could take care of them whenever they needed care, and they're still there today, which I think is a very important strategy for us. And we also moved an on-site nurse onto our Pittsburgh office, and she's a little lonely. We don't have a lot of people back in the office, but she's getting trained up so that she can eventually also offer virtual visits, so our folks won't have to leave the building and can also access that whether or not they have medical insurance. So I think, Scott, I don't know if you want me to continue on this part. I can definitely still address the last two bullets, but I didn't know if you wanted to, your kind of actions that people can take down the road.
So I think it's maybe a good moment to reflect and try to put together what you and Jessica have said. When I've always struggled with the social determinants, because it's like, how am I supposed to, have them live a different place? How do I solve the problem of, like I being an advisor to corporations, and how do I, solve the crime issue in South Dallas as an example, or West Dallas? How do I make sure that they have access to fresh fruits? It feels so overwhelming as a corporation and as a an advisor in my case, but who cares, to do that. But Jessica, when we had our first conversation, you said, Scott, make sure they have access to quality. So instead of trying to boil the ocean and, figure out how to do those things, how would you make sure people have access to quality every time? And I really would like to ask you to speak about that for a minute. And then Tammy, if you would go ahead and go over your last 2 points, because I think that is an example of exactly what you were talking about, Jessica.
Sure. And Scott, remind me if I don't say exactly what you're recalling. But I think this is where the coalition model is really key, and collective models in a region. So, when we think about our membership at the Pittsburgh Business Group on Health, and I'm sure in Dallas, you have a variety of different industries, public and private, academia, all represented. And some of them are financial institutions like PNC Bank, and some of them are healthcare institutions who are associate members. Many of them are universities of Allegheny County, the city of Pittsburgh that we live in. And if we hold each other accountable across those collectively to address these social determinants of health, we can do it. I would expect that maybe our banking industry will lead the way in the economic issue and economic development component. I would expect that our policy and our city and Allegheny County leaders will have a responsibility to look at safety in neighborhoods and policies around that. And I would expect that we, as the non-healthcare industry employers, hold our healthcare systems to really address the fact that people might need a refrigerator for their medication to even be able to be compliant, and that might be less expensive than some service or test that you want them to have, that it's unnecessary. And so we have an opportunity, if we really work collectively, within that model. If we just stay in our lane, it won't work. It will be up to the CEO and the leaders, or even your peers at the benefits level, to go to your healthcare colleague, or your university colleague, or your manufacturing industry colleague, and say, hey, this is the progress we're making. How about you? And why haven't you? And those aren't the questions we're asking. We're not holding each other accountable. And we have an opportunity to do that in a different way. Not only hold each other accountable, I think with Tammy, we shouldn't brush over what Tammy mentioned about be willing to make mistakes. And I know right now it feels, especially in the social media world, I'm very unforgiving, right? You don't want to say the wrong thing. Can you really make a mistake? We can't afford not to take the risk. of making a mistake, as long as we're willing to do something about it sooner than later. And the part of, and the benefits to be more applicable to this audience is the open enrollment period. I know we're in open enrollment season now across the country for most employers. There will be some decisions you've made this year going into 2021 that may not be contributing to a more equitable health condition or environment. You may learn that in 3 months. Do something about it then. Have the conversation with your health plan. Have the conversation with your PBM. Have the conversation with the health system that you may not even actually talk to today, that maybe you need to start talking to. Ask them why the Black maternal rates are 2 to 3 times comparable. I mean, I would imagine if Tammy looks at her data, her Black women maternal mortality rates are comparable to her Mexican women in Mexico, where they have stores. Why is that? When we're paying a lot more for healthcare than Mexico is. So we should be asking our health systems that question, that you want your Black mom and your white mom, who may be sitting in a cube next to one another in a distribution center right next to one another, both do at the same time, both have access to the same hospital. You get there and one can come back alive and one doesn't. That's not okay. And we have not had that level of conversation pre-COVID, pre-George Floyd, and we have the opportunity before us, and we just can't let this time pass. We can't go into wait for 2020 to be done and be happy 2021 is here in January and then move on business as usual. It is not a business as usual time. So I'm not sure if I answered your question or what you were.
Well, yes, you did. And there's one really key point. So one of the things that I have been stuck on, like a conversation in my head that's probably a really stupid, antiquated conversation that you have really helped me with is, I work with a lot of companies that have unions, and I've always thought that access was the top priority of the union, so I couldn't limit access to providers. And I'll give you, and so let me take you back for 1 second to my last life. In my last life, we added over 200 doctors' practices to this large medical group I was in. And my job, one of many things I did, was to go out and to review the quality of care that the doctors were providing that wanted to join our group. Well, not surprisingly, in the areas of lower socioeconomic status, what we often found was that the doctors basically had high volume, low quality, access to care, I guess is a nice way to say it. And, they get people in and out in less than 10 minutes. They charge them X dollars. A lot of it was cash pay. They didn't look into problems. They didn't really help those folks. It was low quality care, and we would not take them in our group. But then when I got working with corporations, I didn't think it was okay for me to exclude low quality providers from the plan, because the unions would be very, very upset. And when we had our prep conversation, you actually challenged me and said that I was thinking about it backwards.
Right. So we have the opposite experience in our marketplace. Actually, one of our largest employers is a school consortium trust, and they are run by their board, which is 50% union and 50% management of the schools, of the various schools. The only way that they were able to really get progress in changing and going into a more value-based network with their union was the conversation of quality. They could not lead with cost. So if you go into these conversations saying you want to lead with quality to address cost, you might lose them. But if you say our people are at risk, that unions care about their people being at risk. You say our people are at risk if we remain, if we keep these providers or these facilities in network, and we have to do something about it. And here's the data to show this to you. We have higher readmission, higher infection rates, higher morbidity, and the union is listening. And they in this case, they made the decision. They voted. It could not have passed without the union's 100% agreement. There was not one person that said no. And that's over 60,000 lives that have been impacted by that level of agreement. And I do think the opportunity in this time is getting down to that. We talk a lot about payment reform, as we should, because the incentives allow for some of these outcomes to happen on these disparities in care. So we should be talking about payment reform, but we definitely need to put the quality of people's lives in the center of that. And that includes in how we engage with our health plans, how we engage with our providers, how we expect our health plans and other partners to engage with the providers, and make that more transparent and visible.
Well, Tammy, that's fantastic, Jessica. Thank you. And Tammy, I want to come to you and ask you how you all are doing that. I want to make one quick comment on the transition. And that is the other thing, Jessica, once I moved over to this side, I had a database with 16 million Americans. And Scott Shainvogel and I were working together to do an evaluation of that. And what we found was in these rapid, I'd call them mills. I mean, I don't want to be derogatory, but they were like healthcare mills. When people would go into those, they'd get referred out at about 5 times higher rate to specialists than in a high quality primary care practice. And the quality of the specialists they were referred to tended to be low, and they tended to get a lot of extra surgery. They tended to get a lot of medications. They didn't get their health literacy around their condition never really improved dramatically. And so they remained kind of just, I don't want to say victims of the system because that sounds negative, but it makes them sound like they're weak or something. They're not. They just never really appreciated what was going on in their body, what their options were, and where they could go to next to get high quality care. And so where you enter the system actually in large part determines whether you get great care or terrible care. So making sure that people get into that primary care, high quality primary care first, with things like what Tammy is doing right now with putting high quality nursing support into the programs that she's bringing, I think is a perfect example of how that will over time, over 3 to 5 years, save a tremendous amount of money for her company. Tammy, would you share with us other thoughts on how you're really focused on access to quality and what you're doing?
Sure. Yeah, no, definitely. And I know I'm actually still on the journey, definitely, but I definitely, over the years, I've painfully learned that, insurance companies, they have contracts. The big four have big contracts with all of their doctors, and they're not going to tell you if Dr. A is better than Dr. B. They just won't. They're contractually bound. It's not going to happen. So I know we do have one company that we work with for expert second opinions, and offering up, surgical and medical decision support. But I am also looking at other companies that are independent of the insurance companies and trying to find out, the best way and the easiest way for the end user to get to the quality care without always sending them out to health grades or, things like that, and having to, or even doing the research for them, which our team does. So that's definitely on our, we want to get that actually in place by January 1st, if not earlier if we can, because it definitely is impactful. But the on-site nurses and health coaches and the on-site RN that we have in Pittsburgh, definitely, you're right, we are looking to see a decent ROI out of that. It's probably going to take 3 years to get it to an optimal level, but it's definitely a worthwhile investment. It's going to pay for itself very quickly. Outside of that, we're looking at what programs can we put into place and the big buzzword right now is deferred care. And, everyone's, putting together their rates for next year and everything else and trying to figure out, what to do. I strongly encourage anybody either make, your vendor, your insurance vendor, show you the data. If you're fully insured, you're self-insured, dig into it because compliance is going off the rails. You have to put in some sorts of programs. You just have to. And if your insurance company doesn't have them there for you, either with a partnership with a third party, that's another action step I would tell you to jump on. Because if you don't start putting programs in place for people to manage their chronic conditions while they're at home, you're going to run into a balloon that's going to pop. And I truly believe that. We're even doing things with digital MSK for the same purpose. So we want to make sure that, we're just addressing basic needs. And back pain's always at the top of the charts, musculoskeletal, maternity claims, I just really, chronic conditions. So doing things now that you can do. To Jessica's point earlier, everyone needs to challenge their medical vendor right now. They're making a fortune. Especially on their fully insured business. I mean, we see it on, the self-insured side. I mean, they have that same deferred bubble. So don't let them fool you. Push them. and ask them for some concessions. I mean, be able to pay it forward to your, your associates or employees, whatever you call them. But it's important right now. We can't not take care of them, and we should be asking them as well, what are you doing? Like Jessica was saying, what is your social determinant of health strategy? What are you doing? We don't have all the data. We don't have ethnicity data coming out of, our utilization reports. We can't even put in like different genders, into our systems right now. So it's going to take us all. It's going to take more than a village. It's going to take every employer to stand up and shout about it, because that's how things get done in this world. So I just, continue to encourage you to be vocal and ask those difficult questions.
So Tammy, one of the things that strikes me, so I have a service that when I was back, being Chief Medical Strategy Officer for that big medical group, one of the things that was really clear to me is that people didn't understand how the system works, how their benefits work, and they didn't understand what they needed to do to take care of themselves. And so the term that I use for that is health literacy, but there's 3 health literacies that we really focus on. Number 1 is health system literacy. Where do I go if I get sick? Number 2 is health care, so the health benefit literacy. How do I pay for it? And am I going to get shellacked with a huge bill? And third is, the self-help literacy. What have you done? So just to finish the story real quickly. So that's what I did when I was, we set that up by having nurses and MAs and things calling people and saying, hey, come in for your appointment, and do you understand why? And they'd have a big conversation around that. And then when I got out of that and came into working with corporations, it became really clear to me the problem is even bigger, because at least people were engaged in it with a doctor, where I was before. Now I got 60% of people that don't go to a doctor in a given year often, if they don't have any incentives to. And so the problem is even bigger. So we started a program called My Personal Health Assistant. Essilor, who actually is a big sponsor and very active in the Dallas-Fort Worth District Group of Health, actually challenged me to create that, and they're then our #1 client. And we literally call their people at risk and say, do you understand what's going on, and how can we support you? And it's been a fantastic learning experience. But we also discovered that the difference between what the people who make the health benefit plan is and their understanding, and the people who are going to be using it, are as far away as the East is from the West. And if you don't really go ask your people, what does this mean? How does this work? How do you engage? Then you have no idea. And, a quick anecdotal story on that is we had a person, this My Personal Health Assistant has been picked up now by a bunch of other companies. One of them had welders in that company, and a welder got a cold and went to the emergency room, and they found he was having a heart attack and he was in congestive heart failure. And they literally rushed him to surgery and did a heart bypass and saved his life. Well, he got out of the hospital, and he was supposed to be going to cardiac rehab and blah, 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 following up with his doctors, and he disappeared. And when the personal health assistant got a hold of him and said, what's going on? He said, I've been telling all my friends, be really careful. If you go to the emergency room with a cold, they'll do heart surgery. No idea what had just gone on and what heart disease was and how it worked. And then the next thing that happened was, so cardiac rehab cost $75 a visit, and he had 4 months of money before he ran out and couldn't pay his bills and was going to be evicted. So, and he's supposed to be paying $75 for 12 visits to go to cardiac rehab. That would have gotten there in about 2 months, in 3 weeks. So by bringing this forward and sharing it with the HR team, they were like, well, let's solve that problem. We're self-insured. We can do that. They solved the problem. He actually ended up back at work before he was actually scheduled to, because he was getting appropriate care. So I think that the gulf between what we think we're doing for people and what we're actually doing for people is much wider than we believe. And if you just bring it to the attention, or the HR department learns about it, they have insight into what we can do.
Mm-hmm. I couldn't agree more. I can share a quick story. We had a gentleman who needed a heart transplant. This was about 2 years ago, and he didn't have our dental insurance, but he needed to have his teeth removed because his dental condition was just so bad. Like, they couldn't do the heart surgery without him having the dental work done. And I know I personally put that up the pole and just said, like, look, this doesn't make any sense. He's already hit his out-of-pocket maximum. He's going to get reset in 2 months. And if he's alive. So, I mean, we made the formal decision to, just open it up, do a, hold harmless agreement, have the dental work done, and let him, get the surgery that he needed to save his life. And I think you're right. I mean, I don't think people understand how to navigate through this at all. And, to make it simpler and easier to navigate, and we consolidated vendors. We've got like the majority of our vendors with one, insurance vendor. Trying to break down those barriers is a huge deal. And you have to have a supportive environment. When I first got into the role that I'm in right now, no one asked questions. No one, we were unapproachable. And it took years to build that trust and that culture around, we want to know. I mean, I just had someone email me yesterday and say, thank you so much for the parenting benefits that we just implemented for children with disabilities. Things like that go so far, and these come from discussions with these, with our associates hearing, we're not getting it from our EAP and our medical, so I think you have to go into this eyes wide open, pay attention.
I'd like to ask those of you who are on this presentation to send in questions. There's a Q&A tab right at the bottom of your screen. If you would click on that and just type in your question. The only stupid question is the one you don't ask. So it's amazing to me how people often start their questions with, this may be a stupid question, but, and they're the most profound questions, because you all are living this, you're seeing this, you're engaged in helping your folks, and we love to have these amazing experts really address and support you. So coming back to something you said a minute ago, Tammy, I hear you describing pathways of care. And one of the things I think COVID has done for us, and is going to really break down the barriers, Jessica, on access, is the telemedicine, video medicine things are being freed up. And so a lot of companies that I'm working with will take musculoskeletal. It's a perfect example. And what you see today is the average person with musculoskeletal disease goes to a primary care doctor or straight to a specialist. 85% of the time they get irradiated, meaning they get an x-ray, and then they will go into some sort of therapy, physical therapy, maybe high quality, maybe not. And then they will go through 2 or 3 visits, they'll get 3 injections, and they'll get surgery. And what we know is that 70% of the surgeries that are done today are not indicated medically. So Jessica, this is where you inspire me, because you said you can say no to mediocrity. And so what I've been going to my companies and talking about is, what if we put a pathway of care in place for musculoskeletal? And it says, as soon as you get pain in a joint, perhaps chronic pain, not because you were playing football and you got your knees taken out or you had a car accident. I'm not talking about trauma. I'm talking about, a new onset or an ongoing chronic pain. What if you went to, and Tammy, you said, a video musculoskeletal strategy.
Digital, yep.
Right, and you did that, and then let me run through the pathway, and you tell me how you're doing this. So then the first step is you go there. You don't get irradiated, but after 3 visits, kind of doing the program 3 times, if you're not getting better, now we need to get you into a physical therapy or your primary care doctor, and that's about 15% of the time is what the studies show, and then you do need an x-ray. And then from that x-ray, you can decide whether you go to something like Regenex, which is non-invasive, PRP or stem cell, or you go to a surgeon where there may be appropriateness now to your surgery. So when you flip it like this, only 15% of people ever get irradiated, 85% don't. And obviously the majority of people get well and never get hurt. So, and then by the way, Dean Foods, Mike is on the board of directors of the Dallas-Fort Business Group, and he worked and set up at Dean Foods where they would only do surgery at high-value centers of excellence if you needed surgery. So what he did was he started to get the best surgeons in the world doing surgery on his people instead of Joe Slaughter, Dr. Slaughter's bar and grill around the corner where, he just is on an insurance company and so he gets to hurt people. And that happens a lot. So he actually closed that window down, and as a result, his folks got much better care, which is exactly what Jessica was saying. So let's just stay on musculoskeletal for a second, and the pathway you're creating, which gives access to quality, which is Jessica's point, and you're actually doing it in the world.
Yeah, we implemented the digital MSK actually on July 1st to make sure that we were meeting the needs of our associates who couldn't go to brick and mortar anymore, and to provide that steerage. Actually, prior to that, in May of 2019, I'm a huge advocate of physical therapy. I think we're one of the, if not probably the only industrialized country that pushes people to surgery so quickly. So we actually expanded out our maximums of physical therapy from 60 visits per year to 120, and also pushed out the authorization process past, instead of it being 5 visits, because after 5 visits, if the doctor was saying this is only going to maintain your condition, it was being denied, we pushed that out to 20 to really try to give an opportunity for the physical therapy to work. And it also works in conjunction with our expert second opinion and surgical decision support. If people reach out to that vendor within 30 days of getting surgery, they are guided to a center of excellence, and they also will receive a gift card for $400. And if there's an alternative therapy, which in many cases there are, they will, gain the knowledge and be able to make a better educated decision.
That's great. It's so fascinating because the #1 surgery done in the United States of America is a meniscectomy of the knee, where they go in and they cut the meniscus out. Wow. There's in the New England Journal of Medicine, there's a study that shows for people over 50, they do better on conservative therapy than getting surgery. So we have a little, this is my personal assistant thing I'm talking about. We actually have a paper we send out when anybody contacts and says, I'm supposed to have surgery done, which, by the way, we had happen. Someone was seen Sunday, they scheduled them for Thursday for surgery, right? And said, this is what you do in America. So we sent them an article. They called up Tuesday and they're like, I don't really want surgery. We sent them the article that showed that, and they canceled their surgery, and they have now never had surgery, and they have no knee pain. So, putting these little blocks in the way is really important. And by the way, Amanda Rudd said, Jessica, I want you to see this. Thank you so much. I recently moved from Pittsburgh to Dallas. I'm so proud of the work being done back in the Burgh. And we definitely need to call to action here in Texas. And so, well, here we are. We're gonna.
Yes, awesome, Amanda. Definitely connect with me. I love when I go to different cities and there's people from Pittsburgh. And I'll definitely be visiting Marianne as soon as we can. Scott, I do, and Tammy, I do want to just bring it back a little bit to our topic. And I think another example that I give Tammy a lot of credit for in alignment with health equity, quality of care, quality of life. When COVID happened, she said, my EAP isn't working. I need to implement behavioral telemedicine. And she did that. She did what she needed to do to ensure access to mental health care. And then when George Floyd happened, she said, OMG, did I even make sure that my mental health care, my newly implemented solution, is it even racially competent, culturally competent? Can it address racial trauma? And I think that's the difference in how we maybe have procured before. What we need to look at for our current vendors and processes: are they culturally competent? Are they truly caring equitably? Even for the best surgeons in the world, in a center of excellence, there's a level of bias. That's the reality. We have data to prove it. Bias is there. Are those health systems, are those health plans requiring their health systems to do anti-racism training? Are they committed to that? Do you know that when you send your diverse Black and Brown population to those same COEs, are they getting the same outcomes as your as your white population? Those are questions I don't think we've been asking before that we need to ask moving forward, so that when we say we have a COE and we're happy with our care pathway, that we know it's working for everybody that we're serving.
Yep.
I just want to
the question that came across is, how do you even start the conversations with your vendors around health disparities? What new programs would you look at with some of this information? We all run RFPs all the time. I know that's kind of all the time I'm doing that. And we're starting to add questions on the RFP to ask those questions, Jessica. What are examples, Tammy, that you've added to your RFPs or that you're starting to have those conversations with?
We're just having direct conversations with especially our medical vendor and our prescription drug vendor to find out how can they absorb ethnicity data if we can get it all into our HRIS system, because they need to start ingesting it and they need to do it historically so that we can not be playing catch up, but get an actual glimpse as to what is going on. Because to Jessica's point, how do we know? Right now, we're at a loss. We don't know if the COEs are treating people of different ethnicities different ways. I think we can make assumptions that they are, and need to put in some controls around that as well. But it's being missed, and like I said, we have to take action to make it happen. So.
Yeah, I think many employers work with consultants. And I'm sure your coalitions will have resources as well. But I think you need to, they're one of your vendors. So if you want the help and the strategy on how to move forward with working with your health plans and your PBMs, you hold your consultant and broker accountable to helping you do that and have them do their homework on how to be more effective at that. And also look at your plan designs and the things that you can control and start there. Start with the areas you can control and make decisions, and start asking, take an equity lens throughout that process, throughout that SPD, and see if there may be potentially circle it. Say, this might be an area. I don't know if it is. Consultant, I need the data run on this. How can we see? We've pushed our vendor at the coalition level really hard to do what they have to do to get that race and ethnicity data, as much race data as we can, and take control where we can. And we're getting that. There's opportunity there. Evaluate, I'll plug that. I think evaluate through the National Alliance. They've had the ethnicity, race, the race and ethnicity, I think, and language data questions in the PBM assessment for years now. And this year they're adding a section on strategy for your health plans on the medical side. Leverage that RFP, make it a requirement. And so there are tools in the National Alliance, which Marianne and I both belong to, have that tool at least right now. So if you don't feel like you can do it on your own, you don't have the capacity, leverage, evaluate, force your health plans to participate in it, and you'll at least begin to see things at your market level that will help you to derive questions at your business level.
It's so interesting, Jessica, because asking the question, Tammy, I'll be right back with you. So, 5 years ago, if you collected that data, then it was assumed you were going to use that against people. And what I hear you pointing out today, it's completely flipped. In fact, it's mandatory that you collect it to make sure you're not discriminating against people, which is a 180 degrees circle.
No, I saw the Q&A that came through, and it points directly at what we're talking about, but a thought popped into my head, because I know I've been looking a lot at financial well-being vendors and things like that, primarily because they're the ones asking a lot of the social determinants of health questions that we want to get to get the answers for. Do you have an emergency account? Are you living paycheck to paycheck? How high is your stress level when it comes to, your finances? And they're getting more nitty gritty than our health assessments, which to me seems really kind of weird. So I don't know, I might travel down that road and start asking our, medical insurance vendor, like, why aren't you asking these questions?
One of the most inspirational things to me, Merck is one of the sponsors today, and they are one of 5 Fortune 500 companies that has a Black CEO and president. And he's actually going through Merck and going right down the line and saying, how are we making sure that we don't make mistakes? There are a lot of great YouTubes where he talks to the Black Lives Matters and the discrimination and how that's taking place, and why out of 500 top companies do we only have 5 CEOs. And in all fairness, he actually looked at his company and said, the reason is because we aren't building the middle management with a racially sensitive lens. And my company's an example. I have failed my company. That will not continue. So really brave and strong leader around this issue. I want to Shristi Shrestha asked the question, and I think, Jessica, this is right in your bailiwick. What recommendations do you have for large health systems to address the social determinants? And I know Pittsburgh has been a hot spot where there have been some large healthcare systems that have tried to strong arm this system because they had so much power. And yet you haven't backed down, and you haven't allowed mediocrity or their autocratic ways to affect what's happening in Pittsburgh.
Yeah, so at the highest, benefits level, in partnership with whoever your TPA is, that conversation and that fight for your lives, that access has to come not only at your price and the price of your people, but at their price. And when I say that, I mean having them answer the questions we just talked about, giving you a full-blown strategy with goals, timetables, and deliverables that they will be committed to. And if you want, put a risk, a payment component to that. Get some cost off of your plan for them not meeting those goals or not really getting to the progress that you're expecting them to get to. So in our market, we had, major competition, largest insurer, largest provider, threatened not to contract, which would provide potential access risk was the argument here and what we were fighting for. And then we started fighting when we thought the contract wouldn't happen for continuity of care, that you have to continue to take care of our cancer patients and those who are, you know, a mom who's 7 months in her pregnancy, now all of a sudden she has to switch doctors. And so we fought hard to ensure during market competition that we address that. And so those are the types of things that you can do at an advocacy level in partnership with your coalitions, of course, and your other peer groups. But I think that the data component is going to be key, because you can't let the wool be put over your eyes. You have to come in informed and start looking at your data in a different way. And so those are a couple of examples. And Tammy, do you have any around the social determinants of health and how we can hold the health systems more accountable? One real quick, while Tammy's coming on, you know, one of the questions we asked was around when everything happened. We were working from home, telemedicine now, people were scared to go to the doctor. We're still seeing the impacts and will for people who had strokes, who refuse to go to the doctors, to the hospital, et cetera. I mean, we're going to see, I think we still haven't seen nothing yet as far as what the data will tell us in 2021. But one of the things we talked about was, well, that's great, but we knew that many of our kids who were at home didn't have access to broadband to be able to even get on school. And I just saw a newspaper article where kids were, their mom took them outside of Taco Bell and they were on their school laptops because they didn't have Wi-Fi. So why are we assuming telemedicine is going to work for everyone in our populations when we know the majority of our people are living paycheck to paycheck in this country, regardless of the industry? So if you know that, maybe they don't have the Wi-Fi. Why isn't your health plan in the business of getting them cell phones or Wi-Fi or VPNs, right? So those are the things I think we need to be talking about around social determinants of health. That is a direct social determinant of health, not being able to have Wi-Fi in a now virtual reality for most of us. Yep. Don't give me, you know, what you're used to giving me. Let's talk about giving out cell phones. And those are the things that I think we need to be talking about.
Well, I think in North Texas, we have a real opportunity, Jessica, because we have two very large non-for-profit companies that make billions of dollars every year. So they put in their foundations, and they don't call it profit, it's called surplus. But I always thought that a non-for-profit would take, you know, let's say that in taxes, you have to pay 20 or 30% of your profit if you're the for-profit company into taxes. In non-for-profit, wouldn't it be wonderful if they were required to take 20 to 30% of their surpluses and reinvest it back in trails, in solving food deserts, in health literacy education, in making sure that they took care to the people? I wonder today, because the game that they play is they have what they bill and what they actually collect, and they take the difference and say, oh, that's our community contribution. Well, that's garbage because they set what they bill. So that just is a nonsensical number. If they actually had to take 20 to 30% of their surplus and put it back into our communities, one has to wonder if we wouldn't make great progress with the social.
I agree. Align those contributions to your actual operating budgets, and instead of these arbitrary numbers. And yes. So,
and you could ask to actually on your next RFP have each health system say what their contributions are before they'll be allowed to be a part of your network. And
I would actually venture to say, like, maybe do it now. Because they don't roll it from year over year. The profits they make this year, they're not going to say they've got the money next year. So even just asking them, you know, along with the other conversations, what are you doing for our communities?
Yeah, exactly.
Well, those who aren't using the care, because they know who isn't using the care.
That's right. And they're serving the people who are going to pay them the most cash, which again goes against the whole concept of non-for-profit. So we kind of stepped into it here a little bit. I want to really, say that our non-for-profit hospitals are incredibly high quality, and if we could spread that to more people, what a gift that would be. So we're going to finish up now, and I just want to thank you so much, Jessica, Tammy, for all you do in the world and for coming and sharing it with us. And around the concepts of social determinants, discrimination, access to quality. I'm so inspired by what you do. So thank you, and consider us raving fans here at the Texas Business Group on Health. For that, I'd like to turn it back over to Mary Ann.
Thank you so much. This has been just the most informative discussion. I thank you so much for sharing just all of these ideas, and I've taken copious notes, even though this has been recorded. That's just a reminder that all of our attendees will be able to download the recording itself. I also want to remind you that we have the feedback survey is already in your inboxes, so please do that right away as soon as you click off or as soon as you zoom out, as I should say. And it'll take you only 2 minutes, maybe less. So I just wanted to remind everyone about this is the last and final session for our TBGH Texas Benefits Forum series. I'm thrilled that we had 140 people registered for it. Maybe you didn't all stay for all the sessions, maybe you didn't stay for the completion of each session, but thank you so much for participating. It's been very encouraging. Upcoming events, we have our 2020 Texas Cancer Care Symposium. The first part, it's in 2 segments. On September 24th, all corporate members of our coalition's employers attend complimentary, so please register your whole benefits team. And then other members have a discounted fee, very nominal. The part 2 is going to be a 3-part workshop on the 3 stages of the cancer care journey, starting with the early prevention and early detection. Workshop 2 is on coordinating cancer care effectively, and the 3rd part is on caregiving and survivorship and return to work. That would be October 15th. And then last but not least is our big annual benefits forum. This year we decided to go virtual and split it up into 2 days rather than a 1 day of 8 sessions. 4 sessions will be on December 2nd in the afternoon, and the other 4 sessions will be on December 3rd. In your feedback survey, we asked you about topics that you want to hear about. Please put some suggestions down, because we'll be looking at that. Our programs committee will be looking at that and considering putting some of your real key issues into that forum. Thank you again. We appreciate your participation, and we appreciate our sponsor support of this. So you all have a great, wonderful, safe, and healthy weekend, long weekend, and drive carefully if you're going to go anywhere, or fly carefully, and take care of yourselves and your families. Thank you.